Dacryostenosis. This is a nasolacrimal duct obstruction causing unilateral tearing and crusty eyes in infants. The treatment is gentle massage of the nasolacrimal sac. 26. Leukokoria. If a patient has bilateral leukokoria, you're thinking retinoblastoma due to an RB1 heritable version. The diagnosis would be MRI, and the treatment would be chemo plus or minus photoablate or cryo or enucleation, where you literally take out the eye. If it's unilateral, most common causes are usually going to be CMV or rubella due to cataracts and retinal detachment. This can also be seen on the NBME with retinopathy of prematurity. 27. Strabismus. The next best step if the patient is less than 4 months old is to reassure parents. Oftentimes, due to the immature extraocular muscles, once they develop, the strabismus will correct. If the patient is over 4 months old, you want to patch the better eye to force the weakened eye to strengthen itself. I actually had to do this whenever I was a child myself. 28. Retinal hemorrhage in a child. You want to suspect child abuse due to shaken baby syndrome. They have vitreoretinal traction, aka subdural bleeding. This is very important. 29. Macular degeneration. Straight lines will appear wavy for these patients, called metamorphopsia. And they'll have impaired dark adaptation. They'll have trouble driving and reading in the dark, as well as a gradual central vision loss. Key here is that it's central. They will have atrophy of their RPE, their retinal pigmented epithelium, as well as the Bruch membrane. And the diagnosis is a screening test, grid test. So they'll see a wavy grid. Dry macular degeneration treatment is smoking cessation and antioxidants. The risk factors are smoking and an age over 60, not diabetes. Don't get tripped on the exam and say that diabetes is a risk factor. Wet macular degeneration treatment, on the other hand, is VEGF inhibitors like ranibizumab, bevacizumab, plus or minus laser photocoagulation. 30, we're going to talk about cataracts. So cataracts present as blurry vision, glare, and halos around lights. Once removed, they do not recur, but you can get posterior capsule opacification, which you would treat with laser. Some conditions that can cause cataracts on the USMLE is classic galactosemia, galactokinase deficiency, the trisomies, Torch's infections, Marfan syndrome, Alport syndrome, myotonic dystrophy, and neurofibromatosis type 2. Another inherited condition that presents with night blindness is retinitis pigmentosa, where you'd see bone spicule-shaped deposits. A classic NBME question is an 80-year-old patient who is always farsighted but is now becoming nearsighted. What's the diagnosis? And your answer is cataracts. So don't forget that cataracts can be caused by glucocorticoid use, especially common in autoimmune conditions for this reason. All right. 31. Angle closure glaucoma. This is going to be painful with colored halos around lights with a pupil that is fixed and mid-dilated. To diagnose, it's tonometry, which is going to show increased intraocular pressure, and you can also use gonioscopy. Treatment is acetazolamide or IV mannitol or timolol plus aproclonidine plus pilocarpine. And then you can also do laser iridotomy or iridectomy. 32. Open angle glaucoma. It's going to be a chronic, painless process of progressive non-reversible vision loss that begins peripherally and centralizes over time. And the diagnosis is going to be tonometry, which shows increased intraocular pressure. You can also use fundoscopy, which show a cup-to-disc ratio greater than 0.5. The treatments include eye drops, so it's going to be prostaglandins, alpha agonists, cholinomimetics, carbonic anhydrase inhibitors, and beta blockers, plus trabeculoplasty if refractory. All right, let's do a quick recap of some of the diabetic ophtho complications. So we have cataracts, which present as blurry vision, decreased visual acuity, and increased glare. The findings show a lens opacity, decreased red reflex, and decreased fundus detail. Glaucoma can be broken down into open angle and angle closure. So open angle will be painless peripheral vision loss with increased intraocular pressure, whereas angle closure will be painful conjunctival redness, corneal edema, mid-fixed dilated pupil with increased intraocular pressure on tonometry. Diabetic retinopathy can be broken down. There's non-proliferative, which would show cotton wool spots, retinal hemorrhage, and microaneurysms. And then there's proliferative, which would have neovascularization. You want to watch out for tractional retinal detachment and vitreous hemorrhage with diabetic retinopathy. 34. Some tricky buzzwords. If you see the word neovascularization, keep on the top of your differential diabetic retinopathy and age-related macular degeneration. If you see hard exudates as a buzzword, you can see that with dry age-related macular degeneration and hypertensive retinopathy.